session to share should be open.
Yes.
Okay. Well, let me end this one.
Hey, thanks everybody. We really appreciate your joining us here today for Georgia MemoryNet Insights or GM Insights. We are so pleased to have Dr. Malaz Boustani, who is a faculty member at the Indiana University School of Medicine. He is the Richard A. Fairbanks Professor of Aging Research. He is a geriatrician, a neuroscientist, and an implementation scientist. And if you wanted to know something about the foundational knowledge about screening for dementia in primary care, you would find his fingerprints and his group's work all over that. And so we're really excited to have him come today to talk about timely detection of mild cognitive impairment and dementia in primary care. He knows a lot about this topic and can get into a lot of the issues about the benefits and sometimes difficult steps about making this diagnosis in primary care. And Dr. Boustani, thanks so much. We'll go ahead and let you start your talk. I appreciate your coming here and joining us today.
Of course. Thank you so much, Ted. Appreciate this opportunity to exchange information with amazing people. I'm going to focus today on this whole concept of timely detection of not just dementia, but also mild cognitive impairments, and particularly in primary care setting. In the current primary care setting, with all the time pressures and everything else you're going through. So in order for me to start, there's some disclosure that I have to make sure you are aware of. I have founded multiple companies, 4 of them. One of them in particular, it's called DigiCare Realized. It's a new company, almost 2 months old, and has a passive digital marker for Alzheimer's disease. So it's very important for you to be aware of that potential conflict of interest. And I also serve on the advisory board or act as a consultant for multiple companies that have a products in the pipeline or very close to be in the pipeline for Alzheimer's disease. And in my institution has managed this conflict of interest. So I want to make sure you are aware of, so you can filter some of the information that I share. The most important thing that I'll discuss with you is trying to make the case of why timely diagnosis of cognitive impairment is important. All right. And then the next one is I'll try to share with you an approach that we are actually testing right now in the real world. And I think from the answer to these 2 bullet points, hopefully I'll give you an insight that will help you out and how to overcome any barriers for the timely detection of cognitive impairment. So here's my why. This has happened to me. I was very, very surprised because I thought I'm the best in detecting Alzheimer's disease and mild cognitive impairment. In a nutshell from this story, I missed my dad's diagnoses. And because I missed my dad's diagnoses, my dad was very, very lucky to be alive. So let me tell you about my dad. So he's a dentist. He was the first dentist in his hometown. He's a masterful in the Arabic language. He taught me poets and writing. Prior to April of 2020, he was not taking any medication. He was walking almost 2 hours every day. That was his routine. He was in his late 70s, so around 79, 80 in April 2020. We think he got a COVID. We think COVID caused myocarditis for him. He developed an AFib, led to heart failure, and he couldn't breathe. And I asked him to go to the hospital. All right. So he was hospitalized. The hospitalization was very straightforward. He left with 5 medications. One of them was Coumadin because of the AFib. And unfortunately, within 2 days, he rehospitalized, that now with delirium. And the delirium in his case was caused by GI bleed and dehydration. And the reason he ended up being hospitalized because I missed the diagnosis of dementia. I didn't think he had dementia. And because he's the dentist, so he was responsible for taking his medication. And he did not do well. And because of that, his INR was very high. He bled, he got dehydrated, got delirious. So if I'm the person who's supposed to teach other people, I'm supposed to know dementia, I missed my dad. And because of my mistake, if you think about it that way, my dad was very, very close to death. And he actually suffered, ironically. So, having GI bleed and dehydration is not walk in the park. And having delirium-induced agitation, he was terrified in the hospital. He was terrified. He was pulling all IV. I had to fight with the docs there to get him out of the hospital right away. As soon as I knew why, we took care of him. And since then, he has not went to the hospital again, because I created a system for medication adherence. It was my wife, my mom, and we took care of him everywhere. Unfortunately, dementia has continued to get worse, but we optimized his quality of life, and he never been in the hospital again. All right.
Oh,
So
Malaz, that makes you both makes you both a provider and a family member who missed a diagnosis of dementia. So you could also offer that up too, because many family members do.
yeah, that is absolutely correct. So I think for me, if I look back and say what happened, there was so many red flags, and I didn't want to hear it. I didn't want to see it. I didn't expect that piece. So there was so many red flags. My mom was telling me there's something going on with the memory. But when I talk with them, I never thought I'm going to do a cognitive assessment and take her complaint. And because he will say everything okay, and I will blame it to my mom. I blame my mom, and I did not go after her red flag, say, your dad has a problem. He doesn't remember very well. And I didn't take her complaint. And if I could just have took her complaint seriously and did a simple mini cog test or anything on him, I would have seen that he couldn't even draw a clock, and this is a dentist. So I could have picked it up, but I didn't listen. The messenger, I didn't listen, and I didn't take it seriously, and I didn't convert her complaint to his complaint. Because if he asked me and said, Malaz, I have a problem with memory, I would have done it. But when the family member came over, I wasn't listening. I didn't see it as a complaint, because he will say everything's okay. So that's really the story of my father, but I think it's very common in primary care across the world. So here's the data to back my statement. This data made me feel a little bit better, Ted. Like I'm not just terrible, I'm not a terrible son, terrible doctor. Unfortunately, up to 80%, sometimes 90% of people with mild cognitive impairment are not documented in the healthcare system. In the best case scenario, in dementia, 80%. And these folks who have undocumented dementia, when we look for them, they have mild to moderate dementia. They have problem in their day-to-day living. All right. And because they have undiagnosed cognitive impairment, this is what happened to my father. He went to the hospital the second time, an emergency room visit. Medication adherence, for sure, that's become a problem. And my father did not have heart failure and diabetes before dementia, but if he had, the management of his chronic disease will be disaster, because he will be in charge of his following the recommendation and management, and he will not have the cognitive capability to do so. He will be at risk for fall. He will be, thank God he was not driving, so the car accident was not. But the big thing, this has happened with my father-in-law, because of his unrecognized dementia, he was a victim of financial exploitation. My father-in-law, he lost close to $300,000 for scammer. So you can see our side of our family, my own biological family and my in-law, struggled with that piece. So this is the reality. Unfortunately, even this reality, even worse if your patient are belonging to underserved minority, like African American or Hispanic, or if they live in rural city. Cool. This number will be even more. So that's the why. Now, you don't see in the why that primary care doctor, there's demand from primary care doctor, from the health insurance. No one is demand for this. This is us doing it because we are a physician, we are nurse practitioner, we're clinician, and we are the only advocate, the only frontliner to help our patients. All right. If we depend on CMS and other people to create demand for us, we will lose. This is part of our oath of do no harm, our oath of taking care of our patient. This is why I went to school, and this is why I became a scientist. So what can we do it in this perspective? One thing I want to highlight again, because a lot of time when people hear undocumented dementia or unrecognized dementia, they think of it as differentiate between undocumented and unrecognized. So here, there's actually the unrecognized 73%, but documented only 38%. So sometimes we think there's a problem, but we don't document it. But most of the time, at the end of the day, the system doesn't know. And because of that, when they go to the hospital, they work with the patient directly on discharge. A person who cannot even maintain new information for more than 3 minutes. And then you want them to follow your recommendation. So solution-wise, this is the big thing. My big solution in the healthcare system, what we're testing right now, is number one, expand the definition of cognitive concern, not just to the patient, but also the family member. So that's number one solution. Don't be like me. When the family members say, I have concern or red flag, look at them as a cognitive complaint, as a chief complaint, and work from there. So that's number one. Number two, if you don't have time and space and everything, we are now using community health workers to follow up on the cognitive complaint. So at least that's a little bit cheap. Number two, if you have community health worker or you decide to do it on your own, taken seriously, you can do brief cognitive assessment, and there's plenty of brief cognitive assessment. I'll share with you one we are doing, but brief cognitive assessment can be done by the community health workers. And based on that, depending on what you want about the diagnoses, you can do automatic referral to memory care practice if you want, or you can just simply do the diagnoses by simply two things. Take the brief cognitive assessment, interview the caregiver about functional status, and simple structure. And between these two things, you can meet the criteria for dementia. So it's not as straightforward. I mean, it's not rocket science. And if there's obviously diagnoses of dementia or mild cognitive impairment, you need to develop a personalized care plan, and you need to monitor it and go from there. So that's, in a nutshell, the straight of the art. The big things start with number one, expand the chief complaint to include family member complaint. If they do, use community health worker for brief cognitive assessment and decide if you can do the diagnoses together with the community health worker, or you can refer to a specialist. So that's in a nutshell. So for us in Indiana University and also in Albert Einstein, we got lucky. All right. We got lucky that in early this year, late last year, we got almost $11-12 million grant to conduct pragmatic clinical effectiveness trial in the real world. All right, in Albert Einstein in New York, in the entire state of Indiana. In that piece, in this cognitive assessment over here, what we're going to be doing, we're going to use something called the 5-cog. And the 5-cog is very, very brief. It doesn't require any kind of informant. It accounts a lot for cultural barrier because it's been developed in people who have less than 6 years of education, African American, Hispanic, and go from there. We are teaming it up with a decision support after. And this 5-cog is very simple. It has a 3-component, simple picture-based memory, simple match test, and subjective questionnaire about motoric cognitive assessment, like in a nutshell, fall risk. And we chose this fall risk because a lot of time right now people say they want to screen for fall, but instead of doing screening for fall and screening for cognitive impairment, the 5-cog can do both. All right. It was tested in 1,200, a randomized control trial of 1,200, predominantly Black and Hispanic, and it increased the cognitive impairment diagnoses by 8-fold. And increase the action by primary care doctor by 3-fold. We have not published this yet. We are working on publishing. We just finished that RCT late last year. Hopefully we'll figure this out. And here's the simple thing. We give them these 4 pictures and we ask them if they remember it. We give them this kind of code and we ask them to decode it. And we ask them 3 questions about fall in a nutshell. That's really take less than 5 minutes. And we embed it in our in Epic and Cerner for us. And we are now testing it in a almost 22 primary care clinic in the Bronx and Indiana. We are enrolling close to 6,600 patients. And we're not just testing the effectiveness again, but we're testing the implementation problem, like the contacts, process, and outcome. And we're doing cost effectiveness to make the business case. So that's in a nutshell my story. I'm sticking with it for now. As a scientist, I will update it. And I want to use the next 14 minutes to answer any personalized question for you within the topic that I mentioned, but anything else you want. So with that, let me stop sharing and I'll hand it back to you, Ted, if you want. How would you like to facilitate the Q&A?
Thanks so much, Malaz. I put some details that you and your team had put in clinicaltrials.gov for folks to find out additional background about the 5-cog trial. That sounds exciting. When you think about, we'll look for questions that appear in the chat. When you think about what are the most common things that you hear from primary care providers about their reluctance to make a dementia diagnosis, what do you hear?
3 things. The big one is no demand. All right. No one, the patient are not knocking on their door and say, I am worried about my brain health. Check me out. So there's the family member, even very rarely until the end, the family member usually are not present in the clinic, in a typical primary care clinic. So you won't be able to have access to their eyes and ears and their story. So I put that under the demand. There's no really big demand. The only demand you have a little bit in the annual wellness visit, but the annual wellness visit, cognitive detection is just one piece of the big one. And as you know, the annual wellness visit has not been uptake a lot. It's been hovering around 18% or so. So it's
18 to 22%.
Yeah.
It seems
So
to be
it's-
about 22% in Georgia when we do a
Here we
spin.
go. It's not really that much. So there's no demand. That's the biggest problem. Number 2, the time. So primary care clinicians have been telling us they don't have the time, even sometime for the 5 minutes, because there's so much on your plate. There's so much on thing. So, and they don't have even time to re-engineer their clinic to accommodate that. And when we work with them on that design time to just re-engineer their time, like allocated half a day, per month or something just for this, use the community health workers, their medical assistant, we overcome the time problem. And the third one for us is the stigma. We found significant stigma that explained the lack of demand. And ironically, Ted, the perceived stigma is more from the healthcare provider than the patient. We did an ARP survey of 40,000 people in 2021, and we found 60% of lay public concerned about stigma. Like if people find out I have dementia or something, they will take away my driver license. You're going to put me in a nursing home and you're going to treat me like a crazy person. 60%. When you ask the healthcare provider think 80% that their patient going to be stigmatized across the board. So the stigma, lack of time, no demand has been really the major barrier. People believe education is the underlying, but this education is not that rocket science. We do much more education. If there is demand, if there's time, and if there is no stigma, I bet the skill set can be obtained very quickly to accommodate this.
I'm going to come back to that in a second, but we've got two questions. Diego Remolina is going to ask a question in just a second, but one question that appeared in the chat that I really like. If the patient complains about memory problems, do you think that this patient might be suspected of having depression rather than dementia? Your thoughts on that clinically?
Yeah, beautiful, beautiful question. The answer 20 years ago would be, oh, I bet they have depression. All right. But what we found out right now, what we call we think right now, any complaint, even if it's subjective, like they have memory complaint, but you do cognitive assessment and their memory is okay. Subjective cognitive complaint is a major risk factor for developing Alzheimer's disease. And so that's the big one we discovered in the past 20 years. Number two, if they have depression, that the driving force for their cognitive complaint, it's technically most, especially if they didn't have depression 5 years ago, this could be the manifestation of Alzheimer's disease related dementia is the depressive symptoms. All right. So for me right now, anybody who complain about memory, I take them seriously. I try to see if there's objective and manage them and follow them. Even if their depression went down and their memory went down, I keep my eyes on them because I know they are at risk of having underlying dementia as the presenting symptoms.
Thanks so much for that answer. I had asked our chair of behavioral and psychiatry here that same question. Very much similar answer. There are situations where you want to treat that depression as part of your overall treatment plan, but this pseudo dementia seems to be a term and a word that's out the window. Hey, Diego Remolina is our clinical director of geriatric services here at Emory. He is an awesome guy, and I think he has a question for you.
Thank you, Dr. Johnson. Dr. Boustani, thank you very much for sharing your personal experience and professional experience. I was wondering if, besides the 3 barriers that you identified, we could add something that I noticed when I do clinical education. I train or I precept residents from the internal medicine training, and I found very often that they are not able to translate clinically the results of a cognitive assessment. So you do a cognitive assessment, you determine that the patient has deficits in cognitive domains, but you struggle as a clinician and primary care provider to translate that into how that looks clinically and what can I do as a primary care provider. And as simple as patient tested positive on a mini cog, they struggle to have this question in their mind: is this patient capable of managing medications? In the case of your father, is this patient capable of meal preparation in settings of recurrent CHF exacerbations and patient going to the hospital every 4 weeks, correct? And when I ask residents, what do you do with this mini cog? What do you do with this MOCA results? They have struggled, they struggle connecting the dots and saying, gee, yeah, this tells me that, is this patient capable of doing basic things that we unfortunately say are basic, and they cannot tell me, gee, the next step is to find out with maybe occupational therapy if the patient is capable of managing their own meds, or correct? So I'm wondering if a 4 barrier is, I don't know what to do clinically with the results.
Yeah, I think for sure, I agree with you. There is some type of barrier, but that barrier in a nutshell, it's driven a lot by the demand and everything else, because what I'm going to tell you, the solution are so simple. And there's managing heart failure, managing what I call below the neck care. It's very complicated, and our clinician are masterful of it. The only problem when you go above the neck, all of a sudden this complexity is surfaced. I don't think it's coming over from skills problem. Obviously, new skills need a little bit of training, deliberate practice, but it's not rocket science. Is the driving force is this, at least from our research, is the stigma and everything. Because I'll tell you the typical thing. We all know as a clinician, screening is not diagnosis, correct? So I'll give you a great example of breast cancer. Everybody will never, ever start chemotherapy after mammogram positive. We all get trained that we will go biopsy to confirm. Cool. And the biopsy, we set up a process for it. So the same thing with a brief cognitive assessment or screen, it's just simply mammogram positive if you think about it, dementia, and you need the next step. The next step is not rocket science. Require 2 things. You look at your cognitive assessment and you get functional status and you see if there's connection. You can do it in 10 minutes. So I can train you on that. The only problem is I can give you that education. If you go back to the real world and no one is using it, then you're not going to remember. And this is going to be our challenge for a typical primary care clinician. They have a panel of 1,500 patients. all right? And that 1,500 patient, only 300 of them are older adults. And now these 300 of the older adults, only 45 are dementia. And only, unfortunately, only 45 have cognitive impairment, 24 have dementia, and you recognize only 8. So you're gonna have to be trained on these extra stuff for just like 45 people out of 1,500. So you're not gonna have enough deliberate practice if you don't reorganize your system and create enough practice to do it. So education, we have to do education for the gap you identify. But if we stop there, you'll come back 6 months later. And again, because there's no demand, they're not going to use it. I remember for me, the central line insertion, when I put central line, in the hospital, I've been doing it all the time. The minute I went outpatient, I don't have to use it anymore. I have zero skills. It will be dangerous for me to use actually central line right now for any of my patients. I hope this give you a little bit of context.
Thank you very much. And I really want to give the opportunity for Owens to talk. I just want to mention it. This is more like a comment. The importance of making the diagnosis is also for other providers that are not in primary care to be mindful about the diagnosis. Just listing the diagnosis is very important. I'm going to share a patient of mine that I saw as a follow-up. I saw her 3 months ago. Some GI complaints and some TMJ complaints. I refer her to ENT, and ENT put her on baclofen for her TMJ problem. And then GI decided that maybe amitriptyline could help with the GI complaints. And I saw her 3 months after, and I realized that, yes, the patient has some cognitive impairment, that I'm working with the patient, but I failed to put the diagnosis. And I'm wondering, maybe if I put the diagnosis in there, that will help providers on this cascade of polypharmacy that could affect cognition, correct? This is me recognizing, gee, I need to put the diagnosis, even if I'm suspecting the diagnosis, because this could be helpful for other providers that are not in primary care. Thank you very much.
You're welcome.
Thanks so much. We have a question from Dr. Gabriela Cohen, who is the course director here and also one of our geriatrician clinicians in our memory assessment clinic at Grady Health System. So go ahead, Dr. Cohen.
Yeah, thank you. Thank you, Ted. Thank you, Malaz, for the great talk. So I work here at Grady at the geriatric clinics, and I'm so surprised as a dementia specialist of the late diagnosis and diagnosis of dementia. So most of the cases I'm diagnosing here, they had dementia for at least 6 or 7 years, and I'm really diagnosing most people with severe disease. So this is like a failure of the system. We fail, at least for each of these patients had 7 years of undiagnosed dementia without any special services offered to them, with multiple admissions, readmissions. So it's actually very sad. It's also very sad that the main diagnosis in this clinic is vascular dementia and not Alzheimer's. But I'm really diagnosing everyone with a CDR of 3, 2 or 3. I'm actually not even picking up patients with mild disease. So it would be nice to know what's the impact, economical and quality of life of these patients who have this missed opportunity for all these years. I don't know. I've been trying to search the literature. There's not that much written about that. I don't know your thoughts about that.
Of course. So unfortunately, your story is national, Gabriel. It's not Georgia specific. It's not Emory specific. We are picking up people, unfortunately, 5 to 6 years. If you just follow the current trajectory of care, you will pick up people with CDR 2 and 3 or MMSE between 10 below 17. So that's or MoCA below 17. So what's the impact depending on who are you measuring the impact? For CMS, they're losing a lot of money, right? So CMS lose a lot of money because of that. Cool. The hospital, they're losing a lot of DRG money. Cool. So if you are in a hospital, lose a lot of money. Obviously, patients and families suffer. There's a lot of potential divorce. I share with you the risk of that my father had, my father-in-law, financial exploitation, everything else. The question is, what will happen if you fix that timely diagnosis? What we're finding out, Fixing the timely diagnoses without coupling it with comprehensive dementia care, it doesn't do anything. All right. But if you're able to put it all together in a package or comprehensive, you save for CMS $3,500 per member per year. All right. And the cost for you to do that is around $1,000. So technically, if you are Medicare Advantage or direct contract company, you make $2,500 margin per member per year. That's a lot of money. Cool. But so that's again the stigma and the demand. The case financially is very clear for the system, the hospital, and for the health, for the patient and the family.
Mainly for the families. They are so alone in this journey. Like, no, yeah, we have different access. Thank you.
Malaz, I'm going to wrap up like 3 different comments and threads and connections, and I may call on Chad Hales to chime in as well. One of the foundational principles of Georgia Memory Net is an early and accurate and specific diagnosis of what is the cause. What is it? Birju Patel, one of our geriatricians who is active at the VA in the cognitive clinic over there, said that it's really important to be correct if you're listing dementia in the problem list, and that folks with other conditions being listed with dementia is not good either. And maybe Chad, if you could come on and just offer the kind of core foundational of principles of Georgia Memory Net of getting that early and accurate diagnosis. Chad?
Yeah, sure. Thanks, Ted. So I think one of the things Georgia Memory Net has tried to do is to get providers to really recognize that concept of making an etiological diagnosis. So, what's the way I describe it to patients and families is what's causing those brain cells not to work like they're supposed to, and try to do a little bit better job than just saying dementia. And you sort of alluded to this, but the challenge as we move forward is we may have opportunities to intervene in some of these patients. And to do that, we got to know what we're treating. Kind of like your comment about the breast cancer, right? You got to know what's going on down there at the cellular level. And so that was one of the kind of main foundations for the Georgia Memory Net is how can we develop a process that will allow us to do that and make that etiological diagnosis sooner, in hopes that as we move forward, we'll have those therapies. So that's the goal.
And I
Thanks,
think
Chad. And Malaz, welcome your response and kind of any wrap-up comments you want to offer us.
Of course, I think the entire dementia care world has changed over the past couple of years, and now there will be penalty if you don't be that specific, at least for Alzheimer's disease, because now we have very close. Hopefully, the FDA will fully approve it. We have disease-modifying treatment for people who have Alzheimer's disease pathology, all right? And these drugs are not walk in the park. They're kind of like a little bit of, they have side effects. So it's going to be very important to do that. So integrating biological diagnostic within our current pathway is going to be very, very important. We are trying to do serum-based right now, and testing and CSF are the only one who are scalable. MRI imaging based for diagnostic confirmation is very expensive. So we hope that blood marker will come over close. In the meantime, we're doing CSF for Alzheimer's disease pathology.
Malaz, thanks so much. We really appreciate your taking out time. Not only did you join us today, but you're going to join us in person later this year at a Georgia Memory Net Primary Care Summit that'll take place at Jekyll Island later on in the year. And so if you are regularly coming to GM Insights, look for further communication about that. Lori Beth, thank you for all of your coordination and work. And you put in the chat a link to the survey so that you can let us know what you thought. Really appreciate, Malaz, you coming and joining us today. Thanks for another record-breaking crowd. We really appreciate you all coming out and hearing more about this. There's a QR code if you don't like clicking on links. That'll also get you to the survey. We'll leave that up for a second, and we know if you have to leave, please feel free to know that we really appreciate you and all of your all of your work. Malaz, one more time, thanks so much. Go UNC Geriatrics. We trained in the same program together. We get to eat dinner together, socialize based upon your being the best geriatric fellow they ever graduated. So thanks so much for coming today.
Thank you, Ted. Bye-bye.
All right, take care. Thanks once again, everybody. Really appreciate you coming on. We're going to end the chat in just a second. So thank you.